Clinical correlations. Ischemic colitis. Ischemic colitis is ischemia and necrosis of large intestine secondary to vascular compromise. It is the most common form of intestinal ischemia, mainly occurs in adults who are above 60 years old. So, in 80 to 85% of the patients, it is mild non-gangrenous form. There are 3 degrees of infarction: mucosal infarction, mural, that is the submucosal infarction, transmural infarction. Etiology. Mucosal and mural infarctions are generally due to hypoperfusion. Transmural infarctions are generally due to acute vascular obstruction due to atherosclerosis, aortic aneurysms or embolic disease. The key features determining the extent of damage are severity and duration of compromise and vessels affected. So, these are the key features to determine the extent of damage. Pathophysiology. Intestinal blood flow of superior mesenteric artery and the inferior mesenteric artery is suddenly compromised, leading to intestinal hypoxia. Because of intestinal hypoxia, it results in intestinal wall damage that further causes mucosal inflammation and possibly bleeding. It may progress to infarction and necrosis, which is a gangrenous type. Disruption of mucosal barrier and perforation causes the release of bacteria, toxins, vasoactive substances, leading to life-threatening sepsis. Intestinal mucosa normally receives 25% of cardiac output, which makes it especially vulnerable to the effects of reduced perfusion. Depending upon the degree of ischemia, there may be 2 types: non-gangrenous and gangrenous. Non-gangrenous, it is around in 80 to 85% of the cases are non-gangrenous. Gangrenous are 15 to 20% of the cases. Sites of compromise is superior mesenteric artery supplies the distal duodenum, jejunum, ileum and the right colon, and from the cecum to the splenic flexure. And inferior mesenteric artery supplies the left colon from the splenic flexure to the rectum. So, the splenic flexure and the recto-sigmoid junction are at a high risk of colic ischemia. So, these are the sites of compromises, that is splenic flexure of colon and recto-sigmoid junction are at a high risk for colic ischemia because they are the watershed areas. And these areas receive dual blood supply for most of the distal branches of large arteries, that is superior mesenteric and inferior mesenteric arteries. So, in the cases of severe hypoperfusion, blood supply through these areas, that is through these end arteries, becomes insufficient, so leading to ischemia. So, intestines can tolerate a state of ischemia for approximately 6 hours. Clinical manifestations of ischemia, that is colonic ischemia. Clinical manifestations are like sudden severe abdominal pain, then abdominal muscular rigidity, nausea, vomiting, blood diarrhea and melinea, means blood in the stools. So, these are the clinical manifestations of the condition, but based on the symptomology, the ischemic colitis presents with 3 stages, that is hyperactive stage, paralytic stage and shock phase. Hyperactive phase. Soon after occlusion or hypoperfusion, sudden onset of crampy abdominal pain, usually left lower quadrant, bloody loose stools, that is melena, and most patients recover and do not progress beyond this phase. Second phase is the paralytic phase. If ischemia continues, pain more diffuse, bowel sounds become absent due to decrease in bowel mobility, bloating, bloody stools cease. It will reduce the bloody stools. Next is the shock phase. Shock phase is acute abdomen with abdominal guarding and rebound tenderness due to perforations and peritonitis. Signs of septic shock. So, a classic case of ischemic colitis is a patient who presents with bloody diarrhea and severe abdominal pain after an abdominal aortic aneurysm repair. So all these are classic cases. So clinically the ischemic bowel disease tends to occur in older patients with concomitant cardiac or valvular disease. Other risk factors include diabetes mellitus, atherosclerosis, congenital heart failure, peripheral vascular disease and lupus. So chronic ischemia may closely mimic inflammatory bowel disease, and diagnosis, lab tests are no specific laboratory findings in mild ischemic colitis, but in severe ischemic colitis there will be increased lactate, increased LDH, increased creatinine kinase, leukocytosis and metabolic acidosis. Imaging, plain abdominal radiograph is enough to diagnose, means insensitive, unspecific air-filled distended bowels are seen in plain imaging but helps to exclude the other disorders. Next procedure is imaging procedure is colonoscopy. May see bloody and edematous mucosa, which are procedure of choice in mild to moderate cases of ischemic colitis. CT scan may show air within the bowel, so bowel wall thickening or thumb print sign. Then exploratory laparotomy in severe cases, that is the possibly with resection, where the complications of ischemic colitis include bowel tissue death, perforation, bowel inflammation, bowel obstruction means strictures, gangrenous form, peritonitis leading to sepsis. Further eventually it leads to multi-organ failure. So there is a high mortality rate when irreversible damage is present. Transmural infarction have a high probability of perforation, means perforating the colon. Complications of ischemic colitis are determined by extent and duration of infarction. If left untreated, the patients can rapidly progress to shock and metabolic acidosis within hours due to a large movement of fluid, protein and electrolytes seeping through the gangrenous bowel, and perforation can lead to profound sepsis. Mucosal and mural infarcts are not generally fatal. However, repeated bouts of injury can set up for more extensive infarct down the line. So treatment for this, treatment consists of bowel rest, IV fluids, intravenous antibiotics, then reduce risk of atherosclerosis, that is the anticoagulation therapy. So depending on the severity and extent of ischemia, infarction, surgical resection of non-viable colic tissue may be appropriate. So in ischemic colitis, the mortality rate is approximately 6%. So this is quite a deep discussion about ischemic colitis. So here we can see ischemic colitis, a colonoscopy, where the endoscopy of ischemic colitis may reveal continuous necrosis in this image and mucosal friability that resembles ulcerative colitis, which is in the left panel, and discrete ulcers with surrounding edema may also be seen in the right panel. And here is an histology of ischemic colitis. At the low part, that is in image A, panel A, there are two biopsy fragments, one of which is normal colonic mucosa and bottom one is which is normal, and while the other, that is the fragment on the top which you can see in this image, is hemorrhagic and has a cleared out spaces within the fragment. At higher point in panel B, we can see at a higher power, and this hemorrhagic fragment has slawed epithelial cells within the clear out spaces. There are chronic inflammation within the lamina propria. The cleared out spaces represent ghost of the colonic glands and they have undergone ischemia. And here is an ischemic image colitis again, where through colonoscopy it is done. So colonoscopy reveals in a patient with ischemic colitis reveals a long, shallow ulcers in the descending colon and in the splenic flexure, both in panels A and B. Descending colon in panel A and at splenic flexure in panel B. Acute mesenteric arterial occlusion with gangrenous ball. So this is the image which demonstrates acute mesenteric arterial occlusion with gangrenous bowel. So the picture shows the appearance of small intestine in a patient who presented with a 12-hour history of abdominal pain, and upon abdominal exploration the bowel was found to be ischemic and a superior mesenteric artery embolism was identified. Following embolectomy, there was minimal improvement in the appearance of bowel and bowel resection was required. So the patient expired less than 24 hours post-operatively. Here is the next image which explains ischemic bowel from acute embolic occlusion. So the picture shows the appearance of small intestine. The operator hand is holding the proximal jejunum, which is relatively spared and suggesting acute embolic occlusion of superior mesenteric artery rather than acute on chronic occlusion. So the more distal jejunum and the ileum are dusky and ischemic but appear viable. And here is a angiography image where non-occlusive mesenteric ischemia on angiography. So it is an anteroposterior view of iotogram. It is of a patient with severe hypotension and shows diffuse spasm of the aorta and all the visceral vessels of the abdomen. Ischemic small bowel shows with arrowheads in this image with which was resected, and normal visceral perfusion is demonstrated in image B. The next image here is CT image, that is colonic ischemia on computed tomography. So the CT scan of the abdomen is from a 72-year-old female who presented with acute abdominal pain. So image A is an axial projection through cecum, and image B shows the cecum and the ascending colon reformatted in the coronal plane. The image shows an accumulation of air within the wall of the cecum. So we can see the arrows are shown here where the images shows an accumulation of air in the wall of the cecum, and this is a finding that is characteristic of pneumatosis coli. Associated radiological findings include a lack of formation of stool in the colon reflecting loss of mucosal function, thickening of peritoneum, and lateral conal fascia which is shown with arrowhead, and ascites which is shown with dashed arrow here in this image, and also no portal venous air was evident in this image. In the appropriate clinical setting, the findings are highly suggestive of acute ischemia of the large ball. Small ball ischemia on plain abdomen film. So here is an image demonstrating the small ball ischemia on a plain abdominal film. So plain radiograph of the abdomen demonstrates distended and featureless loops of small ball with wall thickening, which is shown with the arrow here, black arrow, and separation from the bowel loops, and these findings are consistent with hemorrhage into the bowel wall secondary to ischemia. Non-occlusive ischemia or iotography. So here is the image of iotogram demonstrating diffuse spasm of all the arteries in the abdomen, including hepatic, splenic, renal and mesenteric vessels with reduced vessel filling consistent with non-occlusive mesenteric ischemia. That is, small bowel ileus is seen in the left lower quadrant. And next, here is a arteriography, that is the emboli to superior mesenteric artery on arteriography is demonstrated in this image, where we can see the yellow arrows here. Emboli are shown with the yellow arrows. It is a selective arteriogram of superior mesenteric artery in image A, shows multiple emboli with yellow color arrows. And image B is magnified view of embolus of iliocolic branch of superior mesenteric artery, which is also demonstrated with an arrow mark. Here is the next image of angioplasty and stent, that is the superior mesenteric artery angioplasty and stent is done in this image. So, where the arteriogram shows the filling of jejunal, ileal, ileocolic, right colic and the middle colic arteries, and there is a small amount of retrograde filling of the celiac axis via the pancreatico-duodenal arcade. The stenosis of superior mesenteric artery is not visible on this view. A steep right anterior oblique view of superior mesenteric artery shown in image B shows a short segment stenosis of proximal superior mesenteric artery at its origin, which is demonstrated in thick white arrow in this image. A stent was being positioned in the proximal superior mesenteric artery, which is shown in image C. So, just look at image C, where we can see a stent which was positioned. So, just look at this image C. A stent has been positioned in the proximal superior mesenteric artery in the region of stenosis. A thin white arrow is shown here and expanding using a balloon. A selective superior mesenteric arteriogram is demonstrated in image D. So, this is an image where a selective superior mesenteric arteriogram is done with post angioplasty, shows significant improvement in the severity of the stenosis following stent placement, which is shown with white arrow. So, this completes all about the colon. Thank you.